Hello, good morning.
Good morning.
Good morning.
Morning, sir.
I hope everybody is fine.
Yes, sir.
Yes, I'm fine, thank you, sir.
Good. The semester is gradually shaping up, right?
Yes.
We are heading towards middle of the semester. And when I say middle of the semester, it means that mid-semester is just on the horizon. And I hope you are reading.
Yes, sir.
You can't complain because you have up-to-date, lecture notes. So let's make very good use of that. The last, lectures that you have, even though we did not complete that topic, but I've made it available to you so you can access it on the page. Okay, so as usual, let's begin our journey the way we are used to. Who is going to walk us through the few things we considered last time? Who is ready to? Okay, since you always want to force me before you respond to, okay, now, somebody has come to your rescue. So let me go to Papali.
Hello, sir.
Yeah, hello.
Good morning.
Good
Please, we
morning.
learned about nursing competencies. And we said
Good.
it's when the nurse is able to apply her knowledge in informatics.
Can you pause for us? Somebody is disturbing us.
Okay.
Somebody is also do you have somebody acting as co-host? The person could be, unaware of herself, so we cannot continue update. So those of you who are in charge can put here at the waiting room. Okay, carry on.
Okay, so we learn about nursing competencies. And we say when the nurse is able to use her knowledge in treating the client. Then we talk about the beginners entry, we talk about the intermediate, we talk about the and we say the beginner is when the person
Let me send request to be made a co-host. Okay, you can proceed.
Okay, so the user level or the beginner level is when the nurse demonstrates upon technical competencies, meaning that the nurse can be able to take decision in respect to planning the client treatment or the care of the client.
If the water is clean, is it things that you have washed or both?
Hello, those of you who come and disturb us, are you aware that these lectures are recorded? Are you aware of this?
So the technical competence is when the nurse is able to use the technical competencies or able to use the informatics skills or the ability of the nurse to process informations using computer to care for the client. Thank you.
Okay. That's a very good feedback. But the challenge we have here is that how can we control ourselves? How can we comport ourselves on the platform? Because whatever you are doing here is being recorded. So be aware of some of these things and make sure that when you come here, you meet yourself. If you want to do something, behind the background, you can just unmute yourself, right? You hear me, but your noise will not come and then distract us. Anyway, can we pick another person who also want to share something with us? Can we also get from another person? I want the last person to add her voice to our last meeting. Okay. Rose, can we hear something from you? Rose. 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 Nikara.
Yes, sir.
Yeah, let's hear something from you.
Oh, God. Okay, sir, please, I've also learned about the leadership competency.
Okay.
And then that one, me to my understanding, as a leader or as a nurse, you should be able to perform a role concerning about the nursing informatics. And then you should also have knowledge about how to use the utilities in the facility or the health sector. And then you should have that kind of a leadership role so that you should be able to know how nursing informatics play. That's my understanding. Thank you, sir.
Okay. Now let me pick the last person. The last person. This one is going to be done randomly. Okay. Let me go through the list and then whether you are ready or you're not ready for it. Okay, so now let me go to Cynthia. Don't panic, okay? I know the anxiety, but don't panic. It's normal. Cynthia Candeli. Cynthia.
Sir,
How are you?
I'm fine, thank you.
You can't hide, right? So let's hear something from you. Cynthia,
Sir,
go ahead. We are waiting for you.
sir, please let me organize myself and come.
How do you want to organize yourself? Were you not here last week? You were
Sir,
here.
I was
So
here.
why do you have to permit you to go organize yourself and come back? What did you learn last time?
Sir, last week I learned say I learned the knowledge and then
You are not reading. You are not reading. Good. Now you are telling me that you've not been reading. Okay. Remain where you are. Okay. You're lucky that this is not a classroom. Anyway, let me pick another person. Let me pick another person. Dorcas, AC. Dorcas, AC. Doki, are you here with us? Dorcas. Dorcas, AC, Ashiro. If you are here and you are not responding, yes, tell her that you should get in touch with me after this session, right? Tell her, because you cannot log onto the page and then we call you, and you pretend not to be here. I know you are here. So if she is failing to respond, tell her you should get in touch with me after this session. Okay. Now let me pick from. Yeah, my friend who has raised up your hand, you can go ahead and then give us what you have.
Fair. We
Yeah,
also talked about the utility competencies.
okay.
And you were saying that is when the nurse is able to recognize the relevance of nursing data. And when the person is also able to recognize the limitation of the computer application, that is when we can say that you are utility competent.
So in this instance, does it apply to beginner or modifier? Are you making reference to intermediate, modifier, advanced or innovator, or a beginner entry level? Which of them?
The beginner.
A beginner.
Yes, please.
Okay. Okay. Let's make progress from here.
Okay. So, sir, we also talk about the immediate person too. And the intermediate person too. We said it is when the nurse is able to indicate or demonstrate nursing informatics competencies. This level, the nursing who is practicing informatics must be able to do research with the computer and educate or also have skills using technology in eventful ways. That is the intermediate competency.
Okay.
So under it, we also took the technical, we also took the utility too. So under the technology, we also talk about the support to provide evidence-based practice, synthesizing the data from more than one source. Or sometimes you are able to demonstrate awareness of ability to access data or information in multiple ways. That is when you can say you qualify under the technical competencies. Thank you.
Okay. Okay. I've seen two more hands. Whoever is ready can go ahead.
Dorcas.
Whoever is ready can go ahead and then make your submission. Please do that.
Hello, sir.
Yeah, hello.
Sir, please, this is Dorcas Isi.
Okay, Dorcas, you're back.
Yes,
Okay.
sir, please, I heard you calling my name, but my phone was freezing, so I couldn't unmute myself.
Okay. So now that you are back, we want you to respond to some of the things we talked about last time.
Okay, so sir, last we talked about nursing incompetencies, and I remember we said this what the knowledge that we have in informatics, what you are able to ensure quality, and then about
Network is not permitting you. Okay. So I think we can make progress whilst you are waiting for her. Okay, I've seen two other more students. Please, can you go ahead?
Okay, sir. Please, last week, I also learned about the advanced level. And you said that to be in the advanced level, it means you have specialized in nursing informatics and you are able to use the nursing informatics for decision making and then to develop ways to access data. Thank you.
Okay. Thank you. Thank you too. Okay, so let's move on. So we began looking at concept, theoretical models, and framework in nursing informatics, where we were guided by the levels of skills acquisition as proposed by Hubert and Stradivros, and later applied and then modified by Patricia Benner. So these are the levels of skills acquisition with regards to the use of anything related to informatics, the skills you are supposed to bring on board. Then from here, we move on to relationship between data, information, and knowledge. It became quite clear that you cannot do without establishing parallel linkage or relationship, either between or among data, information, and knowledge, which are the key pillars of nursing communication. So we use quite a number of scenarios or examples to establish those linkages or relationships. And from here, we move on to uses and competencies in nursing informatics, where we further deepen our understanding of beginner, intermediate, advanced, or innovator level of competency, the core skills that pertains to each level of competencies. We align them to the following: technical, utility, and leadership. Okay, so I think then we also introduced to informatics tools, where I said that the tools in informatics are very important, but with regards to this context, I was making reference to that support for data collection, not necessarily the major tools itself, where we look at data collection in terms of questionnaires, surveys, interviews, among others. Now, we also look at the types of nursing and healthcare data, where it became quite clear to us that it could be classified into the following. That is resource data, patient or client demographics, activity data, health service provider data. We are able to compare and contrast activity data and that of health service provider data. We began our journey looking at nursing aspect of health informatics system, though we couldn't finish this, but I'm very sure that we did something. So on this particular one, we were just looking at how nurses use computers or any informatics-based or technology in advancing the course of care delivery. So we began looking at global rules of what nurses in informatics or in caring for patients. We were able to appreciate managerial rules or coordinating activities. Then we also look at physician delegated tasks and nursing autonomous functions. We said that all these things must come together to create a fully operational system that will enhance nursing care plans. Okay, so this is an instance of how we want to see our various world being modernized or modernized. So what you see here is a system that supports nurses at the front of care delivery. And we said that we are used to having, let's say, a table with a computer system that is considered as a tool for managing our patients who are in any of the world that you work in. What you see here has not been the standard way of doing things at our various world, but in some advanced countries, they become very necessary in terms of a patient having a mini computer close to the patient bed. What you see on top here could be as a result of what? Space. So when you don't have enough space to accommodate other equally important equipment, you can mount this or lean this one on top of a board. I mean, the patient bed. But the most important thing here is that you be sure that it comes with keyboard functions that support documentation. Now you also look at how nurses use computers in their daily work or routines. It became quite clear that we have made transition from the old system to electronic health records. So nurses are recently using computers or electronic health records in taking decisions or in managing their patient. For instance, we can obtain information about the past and ongoing treatments and medications. All these are the types of data stored on electronic health records. Access clinical knowledge such as drug information, nursing assessment, articles and nursing best practice guidelines and resources. All these are resources that are tied to the electronic health records to complement nurses in terms of making references or making decisions. Now, to provide information management assistance to nurses, the following are very key. Source data capture, nursing data standards, and decision support system must be addressed to ensure that we have fully efficient systems to manage our patient. So we began looking at source data capture. Why we said that source data capture here means gathering data and information about patient, where it originates, that is with the patient. So on the basis of this, the concept of terminal by the bedside was introduced. So with this conversation, we are talking in terms of how we can bring modernity to our various world. This journey began as far back mid-1980s, right? So you always have to learn from those who have advanced. And that is the reason why we are looking at this. Most experts agree that bringing the computer access closer to the patient, locating it at the point of care is a valid premise, and clinicians appear to favor bedside terminal as a means to reduce the tedious process of documentation. So most clinicians, most practitioners are in favor of what? bedside terminal, that is bringing the computer closer to the patient bed, right? So this is nothing new. It began somewhere as far back 1980s. Now, this is a typical way we can also improve upon, our various work, even though we see glimpses of some of these things in some field works. But we want to ensure that we bring these computers very close to the patient so that any decision that we make, we do documentation or do entries straight away. And once entries are done, because they are unified with workstations or database, infrastructure, it is not going to permit you to, do another entry. That is what? Duplication. Per our current picture, doing Word 1, we are supposed to, do everything via patient folder and later transition those information back onto the computer system. When it happens this way, nurses will not see, the impact in terms of lessening workload. So on the basis of this, when they are brought closer to the patient bed, there will not be any entry of patient information via folder, and later on, you do transfer onto the computer system. No. As more facilities and organizations implement source data capture systems, including bedside terminals, the concept will gain prominence or acceptance. So we are supposed to be canvassing for some of these things in our various world to shape up, things in order to ensure efficient delivery of what? Care. So we can be trumpeting or championing some of these things to improve upon our various world. Now let's look at criteria for source data capture. It must permit nurses at the bedside to interact with what? Main patient database and the main care planning system or hospital information systems. I made a very profound statement that whatever encounter you have with the patient right at the patient bed, those documentation or entry that you make, they are linked to the workstations or the database infrastructure. So this one is not going to allow you to do another entry. Once you do it, they are unified across the centralized system. So that is one of the criteria for source data capture. It must have the capacity to interact with what? Existing hospital information system. So it's just about making sure that they are unified and support exchange of what this information across what continuum of care delivery. Such technology must be small. Now let me go back to the second point. It must have the capacity to interact with existing hospital information system so that effort already expended developing hospital information system is not wasted. So we want to avoid issues of what? Duplication. So whatever entry you do at one point, it is not going to allow you to do another entry. So duplication is what? Avoided. Such technology must be small and compact so as to occupy the minimum amount of space. Please,
talking.
Those who come and they're not compare themselves, you send them to the waiting or just remove them. So the reps, if nobody is acting as a co-host, kindly send requests to make you co-host.
Mute yourself. Laurentia, mute yourself, please. Oh.
I don't have the permission as a co-host, so I cannot, remove or send you to the waiting room. So you kindly send requests to the IT unit for them to meet some of you co-hosts, the reps.
Please, you are a co-host too.
Really? Because I checked earlier on, I noticed. Anyway, let's make progress. Now, such technology must be small and compact so as to occupy a minimum amount of space at the patient bedside, and therefore not interfere with the use of other equally important equipment. What I mean here is that the technology that you design should be so compact, also cute, small. We are looking at space. So whatever is going to be a hindrance, you make sure that those ones are prevented. And that is why in the first slide that I show you, you notice that these monitors are being mounted on top of what? The patient bed. It comes with a keyboard function to support documentation or data entry. So in the same vein, because you may have other equally important equipment, whenever you are designing these technology, take into consideration, how compact it should be in order not to affect issues of mobility. Okay. And then again, you make sure that whenever you also have any keyboard noise that is likely to interfere with patients, who are responding to treatment, you also have to make sure that you minimize those keyboard noise. Then the technology must be rugged and then durable. We want the technology to be able to withstand against harsh environmental conditions. And then again, it should also be strong, so that whenever, let's say, something happens, it doesn't completely get damage. But once maybe it falls down, you can still pick it up. So it has to be able to withstand harsh environmental conditions and ensure that it is strong enough to withstand adverse environmental conditions. It must be easy and uncomplicated to use and have high resolution screens with graphic capability that can be read in the dark. So what I mean here is that as you also design these mini computer systems, you take into consideration, the interfaces. Make sure that the screen has large resolution so that you can make out the content on the screen as it does appear. So that you can see, as I've shown you the slide, make sure that you see all the contents or relevant information on the system. Provision must be made for a variety of means of data entry. So barcode reader should also be an integral part of what? The setup. And then we can also look at what? Digital camera, natural language processing, which will automatically convert, textual information into voice. All these are very important. A volume control is necessary to mute any keyboard sound. As earlier on, I made this comment that we want to make sure patients are not affected by noise. So if you have the keyboard and it comes with some noise that may distract the patient recovery process, it is very important that you minimize that. This type of technology must allow the maximum degree of mobility to enter data whenever the patient is. So there are movable ones where some patients do not stay in their beds. So as they try to even ambulate, you can even use these devices to track them, right? So these are the criteria for source data capture. In the examination, if you are asked to outline 5 criteria for source data capture, I hope you'll be able to outline these points. Even though nobody will ask you to justify anything, but the most important thing is that these serve as what? The major criteria for source data capture. Now, let's look at the types of point-of-care devices. The first is the standard stationary terminal. Which is very important. What we are doing here, it is not just for presentation sake. Whatever we are doing here, we are supposed to be advocating for some of these things to be done in our various facilities. We want to bring some significant changes. So you can also, canvas for some of these changes to be noted in your various work, even though you may not have the financial capacity to handle some of these things. But once we center our communication around some of these things, it may have some impact. So let's try to be advocating for that. So the first one is standard stationary terminal. The expedient approach to the concept of source data capture was simply to place a standard keyboard and monitor at the bedside. So you have a standard keyboard a monitor at the bedside. I think the next slide or the next two will depict or confirm standard stationary terminal. The second one is small footprint terminal. Small footprint terminal, I also show you that one. That is also placed at the patient bedside and having special function keys for data entry. Then the other one is what? Hybrid solution. So we look at what? Analog and then digital features, okay? That is attached to the wall in the patient room when not in use, but it is portable and interactive within the patient room. So that one, it can, it has the features of what? Analog and then digital. And I show you the first one where you make sure that it is firmly attached or linked to the top of what? The patient bed. And this one can support what? Data entry at any given time, especially looking at what? Space and mobility. So that is it. Then this is an instance of what? Small footprint terminal at the bedside. So like I made a very profound statement that the technology that you configure or design, it should be so compact, it should be so cute. It shouldn't, be too big to occupy space. But you can just make sure that it is designed in a compact form so that it doesn't affect issues of what? Mobility. So that is the small footprint terminal. Please, are you following the conversation?
Yes, sir.
Yes, sir.
Please, do you see some of these things at your various wards? Have you witnessed some of these things in your wards or somewhere?
No, sir.
No, sir.
So this conversation is quite new. What I have seen or what I'm aware of, that you go to the various ward. For instance, you can go to labor ward. Then they have, let's say, a table with a computer mounted on it, together with maybe some keyboard that support documentation. So if you're having, let's say, about 15 or 20 beds, that is used to manage the whole patient in that particular ward. But this one, what you are saying is that because when you do this one, there's no way you can do data entries to a daily ward run. You will have to do everything through the patient folder. Then later you transition the information back onto the computer system. You want to avoid this. And that is why we are saying every patient bed should have what? Subsystems, okay? That is the standard way. Now the third one is what? Handheld portable terminal. This one is at least highly favored by quite a number of practitioners because of what? Better access by professionals, better control over access by patient, lower cost, and ease of service and maintenance. So there is also one that is commonly used in our settings here. I've seen one of these things, and some of you can also attest to this one. Okay, so most clinicians appear to favor the handheld portable terminal because of what? Easy access, better control by patient. Better control over access by patient, lower cost, and then ease of service and then maintenance. So these are the instances of how technology is improving our various in terms of what? Managing our patient records. Now, uses of source data capture in healthcare. Nurses document their work and outcome for a number of reasons. The foremost important is communicating information within the healthcare team and providing information for other professionals. So the most important thing here is that we want to leverage on this to facilitate communication among care providers. We want to ensure more accurate documentation of patient care. So it is very important that in the transition of manual information onto the computer system, we can make some mistakes, right? So it is very important that once the system has been configured in a customized way or programmed, it limits errors that may occasion data entry. And that is why every patient bed should have a mini computer that is tied to the centralized database infrastructure that can support documentation. It should be possible to develop and then deliver decision support system for use at the patient bedside. Decision support system is what any computer-based system that is meant to provide assistance to care providers. So it's very important that we want your effort to be complemented by some of these decision support features that can ensure that right at the point of care delivery, you can take notice of what errors and see how you get them resolved. It is also conceivable that this technology must be used for hospital bookings and pre-admission data gathering. It is also very important for admissions, pre-admissions, among others. So let's take note of what the uses of what source data capture. Now I'll pause here before you are introduced to clinical decision support system, which is very, very important, or maybe it can be considered as what new trend support technology, even though it has been in use for a while now. But we are seeing the need to also begin a talk on this to see how best we can harness the full potential of what decision support systems and then its features. So I'll pause here, take some questions or any contribution from you. Then you are introduced to this one in a comprehensive way. Okay, so the time is for you now. Hello.
Hi.
Hi.
Is there any concern, any omission, addition?
No, sir.
No, sir.
No, sir.
You don't have question, but somebody may have a question. So let's permit those who are ready to ask questions to go ahead. Because if you are teaching and then you don't ask questions, somebody may say that silence may concern. But sometimes you need to also be more inquisitive. These are the new dynamics. That is what shaping or changing the landscape of what care delivery. So you have been working with some of these things at your various work. And you need to be more inquisitive. Why this kind of what setup, even though you are quite, you have been really informed about the need to procure some of these things to make sure that things become more efficient. But you can also go extra mile and then bring to bear, right? Okay, to clear some, your curiosity. So let's get to hear from some of you. Now, let me go to Lizzie.
Sir,
Yeah, Lizzie.
please, concerning the types of point of care devices, the standard stationary terminal, is it that that one is big, but it is positioned at the bedside, and the small footprint terminal is small? I don't get the difference. Is it that the small footprint terminal, that one is small, but positioned at the bedside, whilst the standard stationary terminal is big, but equally positioned at the bedside for easy access?
So let me show you this one. Have you seen this one? So the standard stationary terminal, just as you see here, this one, like I said, is laying on top of the patient bed with some keyboard function that support documentation. They have done this because of our space, okay? So when you think that maybe it will affect what? Mobility. Because some of the patients, especially, may not stay in their beds, right? So in order not to distract them, you can just put this one on top of what? The patient bed, and it can still support what? Documentation. So this one is the standard stationary terminal. Then what you see here, that is a small footprint terminal. These are not closer to the patient bed, but they are not laying on top of what? The patient bed. Do you get it? They are just firmly attached or brought closer to the patient bed to support documentation. So this one, you just put it on the table, right? That is close to what? The patient bed. So these are compact one or portable ones. You don't need the bigger ones. And that is why we said that we take into consideration the compactness of what? the monitor or the system that we designed to support this. Then we also have what? This one. This one is more common to our environment here, right? But even though some clinicians favor this one because of what? Mobility, so that is in terms of what? Carrying this one, doing ward round. So most clinicians may prefer this one. But the standard way is that we should have some of these or mini computers not closer to the patient bed. What we see at our previous ward is that you just see one computer being used to manage about 20 or 50 patients. I don't know whether I've made myself clear to you. Lizzie?
Yes, sir. Thank you.
Good. Now let's move on to the next person. I've seen Esther.
No,
Esther?
sir.
Okay.
Sir, please, so the laptop and the iPad we use at the ward, can we classify it under the handheld?
So for instance,
Like
if you are, okay, so the laptop that maybe we use for such engagement, is it meant for one person or it is just for the entire number of clients who are in the ward? Is it for one person or is it just meant for the whole patient who may be on admission?
Okay, for my facility, we do have a computer at the ward, but when the doctors come for us, we do have a laptop, but that one is for all the clients.
Yeah, so that is the system that we have now, right? You say you want to advance from where we are to incorporate some of these or to integrate some of these things so that whatever, we don't want you to move from the patient bed to later come and do the documentation. We want you to do everything on spot. That is the essence of what bedside computing. Right. So I made a very important point that this bedside computing you see are linked to the main source. So any entry that you do, it is sent to those workstations or database infrastructure. So it avoids issues of duplication. Okay. So even though we are not far away from what is required of us, but it is not enough because we should ensure every patient bed has one computer system so that we can do everything before we leave the patient bed. I mean, the patient bedside. Esther, are you getting it?
Yes, please.
Good. Because we don't want you to be moving anything, back and forth. We want everything to be well situated and then includes contact with the patient bed. Okay. Can I make progress from here? They serve the same purpose. Somebody is asking whether they serve the same purpose. But the problem here is that you want effective and then efficient delivery of care. So we don't want you to, even though they are serving the same intended purpose, but we don't want you to do transcription via the patient folder and later on move the information back onto the computer system. We want to ease the burden of workload that nurses shoulder in terms of documentation. So everything should be done once. These are the reasons why some nurses are of the view that they don't see the relevance of some of these technology because they will do everything via the patient bed, folders, and later on move the information back onto the computer. When it happened this way, their needs definitely will not be met because they think of their burden being eased off. And rather, this one is compounding, the already tedious process of documentation. That are being the major setback here. So if you want to follow the standard practice, then it should be that we want to make sure everything is done on spot before we leave the patient bedside. So they all serve original intended purpose, but we want to enhance care delivery. Okay. Now let me go to 02.
Hello, sir. Good morning.
Good morning.
Sir, please, I can see that with these devices, the advanced countries or the developed countries are using it already. So I would like to know, when is Ghana starting or initiating, or some hospitals are already using and we don't know about it?
Oh, but this one, you're already using this, right? But our level, we are used to having, let's say, one computer or two or few of them. That is meant to manage, the patient that you may have at a time, right? And that is why somebody asked a question, whether it serves the same, purpose. The same purpose, but transition may slow, okay? And that is why we said that in order to have effective and efficient care delivery, then everything should be done without wasting time. And that is the reason why we say that doing world round, let's give single attention to every patient before moving away from each bedside. We don't have to come back and then you're doing another entry. The challenge here has been that clinician thinks, because of their work, they don't see the need to do documentation. So they have the view that nurses should do the transcription after ward round. And nurses also think that they are not supposed to be doing that. So a clinician who is giving attention to a patient, let's say right on the patient bedside, you make sure that you are the ultimate, or you are making the decisions. So whatever you do, you make sure you enter all of them as required before you leave the patient bed to another one. Right? So if you are seeing the handheld devices here, I think it is quite common in some of our facilities, right? These are very good for issues of mobility, where you can track the patient with this one, and then if you notice anything, you can also use this one to track that. So we have begun from somewhere. It doesn't mean that we have not done anything at all. For our structure, that is where we see ourselves and where we find ourselves. But we should strive for excellence. And excellence means that we should bring on board some of these advanced innovations to spearhead effective and efficient care delivery. So that's why, okay. So in our small corner or in our own small way, we are doing it.
Yes, sir, please, I'm okay. Thank you.
Now, let's go to decision support system. Decision support system has also been part of the new trends or a technology that has also emerged. And somebody will ask, how would this be distinct from electronic health records? Okay, so how is this distinct from what? Electronic health records. Electronic health records, as we see, is just a common software that is just meant to organize, collect, and let's say store, retrieve, and exchange patient information across the continuum of care delivery. But this one is also a very interesting software that is also tied to the electronic health records. Its major role is to always put in check the activities of the clinicians through all the services that are rendered. These software are used to ensure that right things are done at all times. This stems from the fact that with the kind of autonomy clinicians enjoy, whenever errors go undetected, patient will be the sufferers or the victims of those setback, right, that may go undetected. On the basis of this, we should also consider integrating CDSS system to affect electronic health records. And that is the reason for introducing decision support systems. A decision support system is any computer program designed to help healthcare professionals make decisions or clinical decisions. In a sense, any computer systems that deals with clinical data or medical knowledge is intended to provide decision support. So this one in a way can work as well. Digital library, where all relevant nursing informations are part the way we see on electronic health records. But the major rule is that it always puts us in check to make sure that right things are done. There is a saying that the one who is cutting a path does not know that behind him or her is crooked or crooked. So these are also noted as computer-based form of decision tool, integrating information with the characteristics of what individual patient to provide advice to what patient. So this one feature, the characteristics of our patient. When I talk about characteristics of our patient, you're looking at their demographic information, you're looking at medical history, and any other relevant information that pertains to our patient in terms of decision making. And all these are meant to provide advice to the clinician. Nurses have a unique dual role regarding information as they are generators and consumers of what? Large data set of information. CDSS as a computer software applications that match patient characteristics with knowledge base to generate specific what? Recommendations. So what you have on the system has to do with what? The patient information or the characteristics of what? The patient, the characteristics of what? Our patient. And therefore, the CDSS will serve as what? A knowledge base because it contains repository of what? Patient information or resources. Okay. Decision support can take many forms. And it is what? Integrated into enterprise-wide adoption of what? Electronic health records. It is not intended to replace providers' knowledge or experience, but rather to facilitate the best possible decision with the best information available. Let me reiterate this point. What I mean here is that we shouldn't view this as the ultimate, but we should view this as a complementary tool or augmentary tool, support tool or assistive tool. Okay. So let's take note of it. The way, in the same vein, artificial intelligence should also be viewed as well. An assistive tool and not the ultimate. These are the reasons why, for instance, those people who are doing maybe advanced studies in research, somebody may want to use maybe AI drive. Why should you do that? Because this one is not meant to replace what providers or knowledge or experience, but to support you in any possible way, but not to become the major resource where everything is all dependent on. No. Now, with all of this said, electronic health records are the way of the future for healthcare industry. So electronic health records, regarded as a major software, has come to stay. But as you also have this one for the purpose of data organization, you should also think of what? Optimizing this infrastructure to benefit our patient and hence decision support system. It is a way to capture and utilize real-time data to provide high-quality patient care, ensuring, efficient and effective delivery of what care. Decision support system are computer-based programs designed to help healthcare professionals make decisions and characterized according to one of the following: information management. So that is why we said that in healthcare informatics, we are looking at how best we can rely on robust integrated electronic health records to manage patient information. Then focusing attention, we also want to ensure that we have the needed available information, right, to support care providers at any given time in making what decision. And then the patient-specific consultation, all attention should be given to our patient, right? So whenever we are designing such systems, we take into consideration patient characteristics. Okay. Now, I don't know whether maybe somebody has a question or anything I have to know. Then we move on to common CDSS applications. We are going to go detail into CDSS. Hello.
Hi.
Is there anything somebody wants to know before I move on? Can I make progress?
Yes, sir.
Yes, please.
Let me chip in this before I forget. You have up to date, lecture notes on the V class. So they are accessible. You can go there and then download them. And you also have assignment, even though it is yet to be uploaded. But I think work on that. So within the course of the week, you will get your first assignment. When you get assignment, can you restrain them? Reps, can you, send request for co-host?
Sir, you are a co-host.
Benedicta and then Petran, what are you doing? You said I'm the co-host.
Sir, please, you are the co-host.
And I'm saying that send another request. They will make you a co-host so that I don't also get distracted.
Okay.
Okay. So I was just making a point about your assignment. And I'm saying that the assignment will come with clear instructions and timeline. So if you're unable to do submission of your assignment and time elapses, it will be difficult for you to redeem, yourself in that manner. So whenever you get assignment, normally what I do is that you have 1 week to respond to the assignment. So you make sure that you don't become a victim of circumstance. I know despite, this plenty talk, some students will fail to adhere to this and later on come in with what? Let me say excuses, which will not be entertained. So let's take note of that. Okay, common CDSS applications. The first one is what? Alerting or reminding system. Why is alerting? In fact, this conversation we are having, somebody will be curious to know whether, curious to know the particularities or the practical aspect of what this. This one is just a software. But one of the challenges that we have is that these are for commercial use. So no institution will, distribute their software of this sort for the purpose of teaching. And that is why you are lucky enough, you have access to electronic health records. So per this conversation, it is still going to deepen our understanding of the fact that the electronic health records, even though that is the way to the future, but it is not enough until we have what CDSS and AI elements or features being included as part of what decision making. Okay, so let's view it in that manner. Sometimes we talk about making it too theoretical. So that is why we narrow the conversation to be sure that it becomes very quite clear so that we can apply to real world situations. Now, alerting and the reminding systems, they are systems that notify the clinicians of an immediate problem that calls for a prompt action or decision. So I made a very good point about the fact that the one who is cutting the path does not know behind him or her is what okay. Therefore, you design some of these systems because of the autonomy clinicians enjoy. I remember there was a situation I encountered some years back. You're supposed to serve something like itadopa, right, for gestational hypertension. Then the one who gave the prescription, I wouldn't say the person wasn't experienced enough. We noticed something wrong about the prescription, and then the clinician's attention was drawn to that. She insisted that we adhere to the instruction. Then we were contemplating on that, and then we tried to go to the medical superintendent to also get his views on that. The medical superintendent also insisted that That was also wrong, and therefore we should stick to our claim. But before you could do, the changes, you have to also go back to the clinician to alert her that you also made contact with the medical soup, and therefore you also want to change the order. She insisted that we stick to the instruction. Okay, so with this kind of autonomy, when something goes undetected, if care is not taken, the patient will suffer or dire consequences. So it is very important that decision support system will have a feature that will alert or remind clinicians in case of anything that requires some changes. Right. Another one could be that maybe somebody could be reacting to certain recipient or components of a medication. And on the system, maybe it is not indicated there, or out of oversight, the clinician will not see that and prescribe that. You know the consequences. For instance, if somebody is not supposed to take anything that contains sulfur, and mistakenly the clinician prescribes, let's say, Septrin, which contains sulfur, you know some of these potential consequences. And that is why alerting or reminding systems are very important. So I'll pause here, get you into the conversation. I want this session to be more interactive. Based on the introduction to clinical decision support system, you will see glimpses or signs of decision support elements complementing your efforts or supporting you in any way. Is there any signs of whether maybe you wanted to do something and then you notice unusual errors? The system due attention to that. I want you to narrow the conversation to the routine things that you do, and let's see whether we can identify any alerting or reminding system. Please, did you get a question?
Yes, sir, we understand.
Yes,
Okay,
sir.
so bring out your views. You have been working with some of these things. What can we how can we make what can we consider as an alert or reminding system? Now let me go to Yali, then I'll come back to Suella too. Yali, can we hear you?
Again, if you want to discharge the patient and you've not entered any diagnosis, a red alert would pop up that there is no diagnosis, so you can't discharge the patient. So you have to go back and diagnose the patient before discharge. Thank you.
Okay, so once maybe your attention is drawn to something, until those changes are made, you can't make headway or progress until those changes are effected. Okay, so that's a very good one. Now so we can just start from maybe vital signs through to the things that we do. Okay, anyway, Zuela too.
So, please, in our games system, we have, when you log into a patient's folder, you have a place that they have indicated health alerts or something like that. So when the patient has a problem, like let's say if the patient is asthmatic or the patient is on some medication that needs like 2 hourly or 1 hourly administration, you put it there at the alert system, then you save. So whenever it's time, the system will alert whoever is around with a red indication that it's time for this, or this patient is this or that. So that's my own. Thank you.
So in our own small way, we are all witnesses to some of these decision support features, right? Complementing our efforts. Okay, so that's a very good one. Now let me go to Zelia 2. Zelia 2. Okay, if Zelia 2 is not ready, let's move on to Lizzie. Lizzie, can we hear you?
Sir, please,
Yes, sir,
sometimes
please, with relation to the vital signs, when you are using the LIMS and then you are trying to plot the data you have collected on clients, if you input something like temperature of 38.9, it will give you an alert that the temperature is high. So any input that you made with the LIMS that has a deviation from normal is going to alert you so that you are able to take the necessary interventions. Thank you.
Okay, that's a very good one. So aside the issues of what, vital signs, abnormality, detection, or can you also narrow the conversation to, especially in emergency situations at the labor ward? Can you tell us whether you see clear signs of what, decision support, especially during emergency situations? Hello.
Hi.
Yeah. Did you get a question?
Hi.
Okay, so aside the few things that you have indicated, let's look at how these decision support system affect what decisions at labor ward or maternity. Okay, Lizzie.
Sir, with regards to emergency situations at labor ward, a scenario could be like probably the client have once visited the facility before and was owing the facility. And so probably the client absconded. Later on, the client has been rushed to the facility with an emergency situation. In order to input any lab investigations, in order to carry out your procedure on the client, you will not be allowed, because until the client is able to pay the debts of the previous money she's supposed to pay before discharge, the records people will not even be able to put her in the system for you to even assess her at your labor ward to continue any thing you are supposed to do, despite the fact that you could be able to do some manual thing that will not be queued in by the computer depending on the situation at hand. But when it comes to interventions where doctors have to come in and make some prescriptions, it will not be done. We will not be able to do it, because unless the client is able to carry out the mandatory amount she's supposed to pay before the system is open for us to work on the client, we will not be able to have access to make that emergency move for the client. But in one way or the other, we can be able to adjust and use the certain small things that we have on the ward to be able to save the client. But when it comes to other further investigations and other interventions that has to be done by the doctor, we will not be able to do. Thank you.
Okay, so that's a very good feedback. This is how your examination will look like. So as you're looking at, let's say, alerting the remanding system, then you have what application-based questions. You are supposed to judge whether they are noted as what alerting, remanding, or other common applications. So whatever we are doing here, you always try to make sure that it become very applicable in our settings here. So let's take note of that. Now let me come back to the contribution she just made. Back then, when somebody defaults in terms of what payment, I remember you see accountant and then some few people who be have to track, wherever they are. Some of them could be coming from what? Far to reach what areas. But once they are in debt or they are in arrears, the hospital will have to chase them. Sometimes they go there and then they have gone too far. But with the advent of what? Electronic health records or decision support systems, until all arrears are sorted out, there's no way the system will permit you to go for further services, right? So that is a clear case of what decision support system, ensuring that accountability is always what adhere to. So that is a very good word example. Can we get one more? Can we get one more? Okay, so if you don't have any further thing to say, I think this point is quite clear. These alerts are commonly clinician alerts that appear on the screen at the time of what? Entry of orders, assessment, or lab values. This system may also provide management alert based on problems with an individual patient. So that is what we have reviewed together. Now let's look at what? Interpretations and image recognition. This type of CDSS is one that works to interpret particular data, such as electrocardiogram or blood gases. So the electrocardiogram is meant to measure the electrical activity of what? The heart. Such a system or a system such as this work by assimilating the data and transforming it into conceptual understanding or interpretation. So to use the data, process it or transform it into the way we have to understand. The interpretation is then presented to the clinician for use in decision making. So what are the clear signs of what? Interpretations or image recognition exhibited by decision support system. So let me just open up about this one. We are looking at what? S3 services, magnetic resonance imaging, ultrasonography. We are looking at computer scan tomography, among others. These are very common in terms of what? Interpretation or image recognition. And with the advent of what? 2D, 3D, and then now looking at what? 3D together with what? Artificial intelligence. These are very important because we may have inexperienced clinicians who may encounter complex what? Medical conditions or diagnoses that they may struggle to come to terms with. On the basis of this, we need advanced decision support system to complement clinicians through ensuring interpretability and that of transparency. So, who can also give us a clear case of what? How decision support system guide care providers in the right interpretation and transparency of, let's say, radiological images or X-ray, like the other ones I mentioned. Now let me go to Laurentia.
Yes, sir. Please, with the anomaly scans, the midwife or the doctor who will do the review can be able to interpret to see if the baby or the growing fetus has a normal feature or any disability that can be attended to. Thank you.
Good. That's a very good one. So if you are having any undetected maybe anomalies, it is the role of the system to bring to light so that the care provider is made aware of the new changes and enforce that. Can we get one or maybe more? Can we get one or more?
Sir, this is Lizzie.
Yeah. Good. Lizzie, good.
Yes, sir, please. In relation to what our sister has already contributed to, I'm talking in a similar way. With regards to lab investigations, let's probably say the clients come with preeclampsia and then doctor has requested to do chemistries. Okay, so when the lab results comes out, the doctor is looking at the figures ranging in the uric acid, the BUE creatinine, and then the LFT. Depending on the figure range, we'll tell the doctor whether an intervention has to be taken or not. Thank you.
Okay, so that's a very good one. That's a very good one. So we had, if you look at this space, it transforms it into conceptual understanding. This is very important, especially when we encounter clinicians who are inexperienced and they are supposed to interpret this in order to arrive at what diagnosis. So if they're unable to see it or it doesn't become more transparent for conceptual understanding, then you know that there's no way the patient good benefit from what? Care. Because you'll be diagnosis will be mismatched with what? Prescription. And that is why we want to ensure that we get it right. Okay. And then this one is also very important, especially as we want to see our patients in their numbers every day in our hospitals. Those people that will request SV services for them or radiological services, we can ensure that when their results are ready, we can find ways and means to send them. It's like the microphone is not okay. Now I think you see, as I'm here, but those people who are making noise, their microphones are not open for me to detect them. Okay. So those people who may come and then their results are not ready, if you can have a system that is made accessible to them, then we can send them, their results. But that is, we are not there yet. Okay, but as we are going forward, as we want to have a more integrated, system, we should also consider, the patient having access in order to prevent them from covering so many marks before they have access to some of these things. Okay, so it is very important in radiology, as in X-ray, MRI, ultrasonography, computer vision, among others. All these are very important. Okay, so let's make progress from here. So in examination, I can ask you a question, and based on the question, you should be able to decide whether the option may exemplify the statement. The option could be interpretations or image recognition. But one thing that is also very important is we have something called picture archiving and communication systems, PAC systems. They are also very important part of what electronic health records or decision support system. Interpretation of radiological images are very important. If you don't get it right, the patient will suffer. So the PAC system is the one that brings, brightness. When I say brightness, what I mean is that it will make, clear interpretation to the care provider. So the PAC system is very, very important to make sure that those complex or medical conditions that are difficult to visualize, the care provider is able to see that and make a decision. So the PAC systems are integrated subtly into the electronic health records to assist the clinician in such a manner. Now, let's go to assisting. A system that is used to simplify clinician interaction with the computer is classified as assisting system. Assisting clinician interactions. This system usually assists in the ordering or charting process by offering the clinician such things as standing order list, patient-specific blood dosing, appropriate parameter for charting based on their earlier identified problems. So these are very important for requisition to all the requests that emanate from the clinician end. These tools aid as assistive or assisted to the care provider. They are not the ultimate, but they make sure that right things are done at all times, right? So for instance, how can this technology also assist nurses? Recently, I have been looking at how best we can improve upon nursing handover communication, leveraging on artificial intelligence. So it is very important that in handing over or in shift, if writings or communications are not clear, we also know the consequences. So it is very important that in order to avoid the tedious process of documentation, whatever word or whatever textual information nurses have, through the use of what we term as large language models, built on ChatGPT as an interface, it will convert all those textual words into voice that can make summaries of what handover to support what effective workflow among what nurses. So it is also aiding as well an assistive or assistant to the care provider, and that is also very important. Please, is that quite clear?
No, please.
You said no, please. Okay, this is more technical, right? What I mean is that, we are used to the manual way of what handing over, right, or handover, and because we are going paperless, we want to make sure that everything is what well integrated. So if you are doing manual handover, then it means that it is not unified across the electronic health records, right? So we want to design a system that ensures that nurses are able to do proper handover through data summarization and effective workflow. And I said this one can only work. What you have to do is that we train large data set of what nursing information, right, on large language model. Once we train large data set of information on large language model, and then we also have inbuilt of ChatGPT as a communication interface. Whatever textual information we have, the system will convert it into voice that can be transcribed to support communication. So instead of going manually in the handing over, we want to ensure that we can have for ChatGPT that will serve as an interface communication that will convert the normal manual way of information into voice that can be integrated into the electronic health records for the purpose of data summarization, predictions, and then decision making across all levels of care among nurses. Please, are you getting it?
Yes, sir.
Yeah, I said this one is more technical, but let's regard this one as all the requests or requisitions that emanate from the clinician. It is just meant to complement the clinicians in that kind of structure, but not to be seen as the ultimate, right? Okay, now Lizzie.
Sir, with what you are saying, I want to understand it well. Could it be that the inventories we do on the client, is it also in relation to the assistant of this thing you are talking about?
Yes, all of them are part of decisions, right? So they are part of the request that we make. So all of them are there. So if you're making requisition or you want to make order, and let's say they are not enough, once you prescribe more than required, the system will have to prompt you that you cannot, exceed the total number of available, maybe consumables or drugs. Are you getting it? So all of them are part of assistive too. Are you okay?
Yes, please.
Good. Any further question? Okay, so let's make progress from here. Now let's go to critiquing system. Critiquing system is one of the, as far as I'm concerned, even though it is still in the developmental stages, but it's one of the most important part of CDSS, even though at our level here, it is not quite clear, but that is why I said it's still at the developmental stages. Such systems that do this are in the research stage and not yet available for implementation. This type of system is designed to critique a set of orders for a particular problem. For example, a clinician might enter orders for change in respirator settings, which the system will then critique in the light of the most recently entered drug gases. The clinician will be presented with an alternate set of orders and the rationale for change made. The clinician will have the option of accepting or rejecting the changes suggested by the computer. Now, I will also have to pause here. Critiquing system, meaning that it is not going to be too judgmental. but they're just going to make it constructive, okay? It comes with what, some clear rules, or they are considered as what, predefining or predetermined what rules that guides the clinician in making what decision. So it is not going to be self-imposition, whereby it becomes what the ultimate. The clinician will have to weigh the options provided by the system, match it with what his or her experience, decipher between the two, and take what final decision. The system, if you think the call is not right, the clinician has every right to hold on to his or her view based on his experience or knowledge, right? So I'll pause here and then see whether maybe you can give a clear case of what critiquing system, whether it is possible. We have seen maybe an aspect of it, even though I said this one is in the developmental stage, where maybe order is made or request is made, then the system will just make certain suggestions or recommendations based on certain rules, okay? Then on the basis of that, you change your order or your request, or you think that what you are doing is the right thing, and therefore you hold on to your claim, then you move on. Are we seeing glimpses or signs of this, or it is still in the developmental stage? What do you say to this? Hello? Okay, now let me go to Lizzie. Oh, it's been, I mean, one-sided. Anyway, Lizzie, let's go.
The place the critics. I think in our field of work, sometimes in regard to dosing, the dosage of the drugs that doctors prescribe, or maybe midwives sometimes we prescribe. Sometimes, let's say you wanted to give a dose of max of it, but sometimes when you request, because of the quantity you want, it when you request like maybe 5 milligram or 50%, the system will tell you that depending on the quantity you want, they will not be able to give you. But sometimes when you just make it a whole, like 45 milligram starts, that one, they will give it to you. But when you have to expand it to the required number of the 9 ampoules that you wanted, sometimes the system will reject that. They won't give you. Another example too will be like probably a client has to come into the ward, maybe the client is coming for a review or something, and then you input let's say the client is coming for hypertensive review, then you input the drugs. You realize that probably the date that has been given to the client previously, the medication should not be able to elapse, but probably the client comes a week before the actual date that the client is supposed to be reviewed. So you realize that when you input the drug into the system, it will tell you that the client is already having some of the drugs with her in this, and so they'll give you an indication whether you should proceed to further give, or you wait till the right date elapses for the client to receive the medication at the right time. So depending on whether you continue to give the drugs or you wait till the end. But I think even though you cannot wait because the client is already with you, so the only thing you do is to forward and continue to prescribe that drug for the person to go and think. I think that is my take on it.
Okay, so these are evidentially, use cases of decision support system or critiquing system. So I think that's a very good one. But I want to find out whether the system come with some rules. Maybe if this one is not right, then do it this way. So the system will always make suggestions. Does it come with some suggestions or recommendation for you?
No, sir.
No, sir, right? So if it doesn't come with some recommendations or suggestions, then it means that it's still within the developmental stage. You want, a system that can always, not necessarily to challenge what the clinicians, autonomy, but I just want to shape what the care provider or the clinician to make sure that right things are done at the right time. So in terms of these decision support system, they are for specific purposes. These features of decision support system, you can have something with them as you can read around them when you have period. We have something called mycin, MYCIN. It is just purposely for the management of what antibiotics. So that is what the software that it comes with. We also have what internet one, and then we also have what quick medical reference. All these are features that contains several medical conditions and diagnoses. Whenever fall off, you don't stay functioning with regards to that. The system ensure that you do the right things at all times. Now, let me cite a typical example of a critiquing system based on certain predefined rules, just to make us appreciate this concept better, even though it is still in the developmental stage. Please, can we restrain? Microphone doesn't open for me to clear them off. My friend, okay, I've seen somebody's hand. Please, can you go ahead and then take your submission?
Okay, sir, please, I wanted to give an example and also ask a question. I wanted to say that an example is like you want to treat, a doctor wants to treat a client with a bacterial infection. So the doctor inputs an antibiotic into the system, but the patient have a renal condition. So the system informs or criticizes the choice of the doctor's antibiotics, telling the doctor to choose another antibiotic because what he has chosen will cause more renal problems to the client who already has a renal problem. That's the example I wanted to give. And I wanted to ask that what is the difference between critiquing and alerting and reminding? Because with the example I've given, I think alerting and then critiquing are some ways similar. So I wanted to ask for the difference between the two.
Okay, critiquing feature will always come with what? Some rules, okay? It always works in line with what? Oh, somebody is disturbing us. The critiquing system, this is how you should view it. It always comes with what? If then rules. The way the setup is, okay. Please, can you hear me now?
Yes,
Yes,
sir. Please.
Okay.
Yes, sir.
So the point here is that the critiquing system is always dependent on if-then rules. Okay, if-then rules. So always it comes with us specific rules as to why the system things like, for instance, you're looking at, let's say, AI, where sometimes maybe you can even chat with what AI. Are you getting it? And the AI can even suggest or make recommendation as to how you should approach A, B, C, D. In the same vein that the critiquing system works. But you see, even with the AI, sometimes it can be recommendation or suggestion, but based on your own understanding or knowledge, it can also deviate from what? That. Are you getting it? So in a similar fashion, that is how we should be what? Critiquing system. Do you get it? Then the alerting or the reminding system is just to prompt you, just signal you without what? Necessarily giving you what? Some rules or being judgmental. Are you getting it? So that is the difference between the two. So let's further deepen our understanding of what, let's say, the antibiotics you use to buttress a point. For instance, if a patient has maybe certain conditions, let's say, for instance, let me put it this way. let's say a patient is having upper respiratory tract infection, and therefore you have prescribed, let's say, amoxicillin capsules, or let's say erythromycin, right? Maybe based on how the system has been trained, that is the critiquing system. It's just something like a model based on how they have been trained. Maybe they are also used to something like amoxicillin, okay? So the system can see that if patient has, let's say, upper respiratory tract infection, and lab results is A, B, C, D, then suggest antibiotics, amoxicillin. So it will just help you. The mycin will help you to, let's say, identify the likely, let's say, infections or pathogens, right? Then it can suggest the right antibiotics. You can have several antibiotics, right? That is why I said mycin comes with several antibiotics in its structure. So what you do is that the system will always, be to choose what it tends will manage the situation better. Okay, so that is for mycin. And then again, another clear case of critiquing system is that if a patient is, let's say, prescribed medication S, and has allergy Y, let's say Septrin, right? And you also have maybe allergy, or those people who are victims of UCDP, among others. Then you can alert the nurse or midwife of potential reaction, okay? If the patient vital signs also indicate sepsis risk, then you can prompt the nurse to follow sepsis protocol. If lab results also shows abnormal values, then the nurse can suggest review of medication dosages. So these are clear use cases of critiquing system. Okay. Please, I hope I'm communicating to someone.
Yes, sir.
Yes, sir.
Yes.
So in your examination,
Sir.
these are the things you are going to witness.
Yes.
They are going to be application-based questions. So let's try to make sure that, even though I'm in haste, but I need to make sure that you are getting, the pieces very well. Alima too.
Yes, sir. Sir, please, if I understand you well, example in a setting, when a woman is in labor and then you realize that the contractions is not going as you expect it to be, and then you wanted to increase the dose of oxytocin, and then with the critique system, it's telling you that the fetal heart rate is reducing, and comparing it to the dose you want to increase pertaining to the oxytocin, it will further decrease the fetal respiration, and then it will lead to fetal compromise. So if I understand your explanation well.
That's a clear case of the taking system, okay. But in our settings here, I think we have not advanced to the level where these systems will come and then challenge, clinicians or decision-making abilities, right? But just a gradual process as we are starting from reminders, among others, with the AI systems being inbuilt into electronic health record together with large language models, which will train large data set of information. And those algorithms, once they are trained on these large data set of information, then a clinician will be at peace with themselves in terms of decision making. But we are not there yet. It's still within the developmental stage. Okay, I think time is almost up. So I will just look at one more and then we call it done for today. Okay, so we now understand, so please, you can read around the critiquing system, right? If then rules. Okay, now diagnosing. This type of decision support uses general assessment data to generate suggested diagnosis. This system may then ask for additional data so as to rule out, rule in, or otherwise refine the list of what diagnostic possibilities. The system comes with what so many diagnoses of medical conditions, and if clinicians encounter complex medical diagnoses that may seem unrelated, this system can be suggestive or can suggest what some of these diagnoses that may be in line or match up with what the required prescription, right? And that is how the diagnosing also work. I think I will have to pause here. Then let's take note of where we have reached. Then we carry on from here in our subsequent meeting. You have what managing. You have managing, information retrieval, prescription decision support. Then we look at the need for CDSS and possible disadvantages. Then we look at what knowledge-based and non-knowledge-based CDSS. Please, so you can read around this one ahead of our next meeting. Knowledge and non-knowledge-based CDSS. On this note, I'll pause here, then take 1 or 2 views before we end our proceedings. When is it confirmed for our mid-semester exams? I said time with the mid-semester, right? Have you been told when you are going to do it? When are you going for the Easter break?
We don't know. Break.
You don't know.
We are part of the Easter. Examination, end of semester examination starts on the 10th April to 10th May. So I don't think we are part.
The Easter break is first weekend.
What do you say? Why do you say you are not part? Because
on the timetable is there.
You have academic calendar. Calendar should guide you as to when you are going to do your mid-semester. So go through the calendar and then confirm when you are going to do the mid-semester. And those other courses that you have been doing, have they also confirmed you when you are going to do your mid-semester? You haven't spoken about it, right?
Hello, sir.
Okay, so I can also.
Sir.
Okay, hello.
On the calendar, May semester will start from the 6th to the 15th. That is what is on the calendar.
Okay, so meaning that we can have our meeting next week, right? And then maybe the following week for May semester. I hope that's okay. I want us to have consensus.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Next 2 weeks.
Yes, sir.
Because we have hit the middle of what we are supposed to do. And I think to consider May semester. Please, there are going to be application-based questions. And this one is going to guide you to know the patterns of questions to expect in domain exams. So those of you who have not started reading yet, please do the needful. Informatics is a course you can simply get your A or B, but it can also be a tricky, environment for you. So let's take that into consideration. Then our time is up. So thank you all for your commitment to this course. I wish you very well in your subsequent meetings. Until we meet, make sure that we stay very safe. Bye-bye.
Bye.
Bye, sir.
Thank you, sir.
Bye.
Bye.
Bye.